think these multi-stakeholder events are very powerful. We all have a hand to play in the healthcare ecosystem and the mess that is what it is today, and we all have a role in figuring out solutions together. So I think these conversations are very important. So I wanted to provide a very quick summary of how, from the Boeing Company, how we view our healthcare strategy, and then dive down into some of the more innovative things that we're doing. And when we look at the healthcare problem today, we do a lot of, I guess you could say we deploy a portfolio of strategies to kind of combat the problems that exist with the healthcare model. We do a lot of the stuff more traditional employers are doing. We strongly believe in high deductible health plans. We feel employees need to have skin in the game. We believe in our wellness programs. For Boeing, it's pretty easy to make those investments because we have long tenured employees, and we typically get paid out on those investments. So we're very strong in that category. We also strongly believe in providing really good cost and quality data for our employees to make good decisions. So that's all kind of on the demand side of the equation. We believe in that, and we want that to all succeed. My view is that will do some good for curbing healthcare costs and improving quality, but it's probably nibbling around the edges if we can't really step into the supply side issues that exist in the healthcare space. And that's why we've moved to doing a fair amount of direct contracting with providers, and we feel like that's a good opportunity to have a seat at the table and influence the provider community directly. And we're active in three primary areas in that space. We have a Centers of Excellence program where we contract directly with various systems, very high quality systems around the country, and we're willing to ship our employees to those systems. Cleveland Clinic, for example, great data on hearts. We're happy to ship our folks there. That's not particularly new for us. We continue to do that and believe that's a good strategy. The more innovative areas and big areas that we've been working recently is our accountable care organization direct contracts that we've been doing. We've been doing those for a couple of years. We launched in 2015. We have 4 around the country: Seattle, St. Louis, Charleston, and Southern California. And there's certainly an element of scalability of those, which I'll talk about at the end, and that'll lead into what Rashika will talk about with IORA. But the basic premise of these ACOs is we provide a strong incentive for our employees to get their care at these accountable care organizations. That pushes revenue and volume to these integrated health systems. And in return for that, they guarantee us quality, they guarantee us financial outcomes, and improve the member experience. And the premise is if they're getting their care there, the systems, and if they're getting their care there and they have a long-term incentive, financial incentive to manage their care better, they will make the investments necessary in their infrastructure to better manage those patients from a clinical standpoint. So I'd say we're very pleased with these, with our accountable care organizations so far. The quality has been definitely improved versus our unmanaged population. Pretty good demonstration of that. From a financial standpoint, I don't want to look at it in any one given year. There's still some actuarial noise that happens in these models, just because even our population is large. It's small when it comes down to the bigger pool that exists in the healthcare market. So there's a little bit of noise there, but I'd say overall, financially, this has been a nice win for the company. It's been a nice win for our employees. I'd say it's a nice win for providers. I don't know if they'd all say that, but we think it is. So I think it's been a short and midterm win. But what we're really driving for is healthcare transformation, and we want to see the delivery systems change the way they deliver care. And so I'll give you one example that we're seeing that we're excited about, and then I'll start talking about our scalability. Before we did these ACOs, there was virtually zero depression screenings happening at the primary care level. And we installed that as one of our contract requirements when we set up these ACOs. We required the primary care docs to start doing depression screenings. And we recognize that's a tough thing for a primary care doc to do, maybe not something they're necessarily trained in. Same thing with having a conversation about BMI. These are tough conversations, but what we've recognized over the years is our employees, as everybody would imagine, they trust their doctor. They don't necessarily trust the company all the time. They don't trust insurance companies. They don't trust third parties that we're having coach them. They trust their doctor. We need to require the primary care doctor and to have these tough conversations a lot of times, and give them the tools to be able to do that. So we've seen a very good progression on the number of depression screens that are happening at the primary care level, and all of our ACOs are very active in installing behavioral health clinicians in the primary care setting. And if we think about that from a patient experience, if you go in and if you have some behavioral health issues, to be able to walk down the hall and do a warm transfer is a very effective way. We know there's a ton of access problems in the behavioral health space today. That's hugely important. It's also great for the doc to also have a colleague in the office to be able to go connect directly with. So we see that as a very good win. I think the fact that we're holding the provider systems accountable is driving some of those decisions about how they're investing in the infrastructure, because I don't know the reimbursement mechanisms were in place to pay for this previously, so that's why it wasn't done. The other thing we're working on is having telemedicine approaches to behavioral health, where when a patient calls in, they immediately talk to a psychiatrist or a psychologist. They're not talking to a coach or a planner, and they're not waiting 4 weeks to talk to a clinician that can help them directly. So we're investing heavily in this area with our ACO partners. We think this is going to be a really big win, and as we all know, that depression is comorbid with every other condition. We had an employee who had a dependent that went to the emergency room like 35 times in 1 year, and it's like, how does that possibly happen? And it doesn't take too many of those. I mean, we think of how dangerous that is for that person to be in the emergency room that many times, and how expensive that is. It's just, there's these people fall through the cracks, and so we really need to kind of tackle this behavioral health issue. So we're very, very pleased. That's one kind of narrow example of what I think these new conversations and this new driving accountability back to the providers to manage the population are doing. So as we've been thinking about how do we scale this, certainly these are bigger negotiations that we've done in areas where we have a critical mass. We would love to bring this value to all of our areas, but we do have a problem of scale. I mean, we have people in 48 states or 49 states right now, so obviously this would be tough for us to manage. So what we're experimenting with in Phoenix, which we're really excited about, and Rishika will talk about the details of the program, is with a company called IORA. And they have a really effective team-based approach to primary care. And we, from Boeing, will just pay them a fixed monthly cost. It's free for our employees to go get as much primary care as they need. And our feeling is this will more than pay for itself as we are able to more effectively manage these sicker populations, reduce inpatient hospitalizations, reduce ER visits. We're pretty bullish on this being a good play for the company. So, and then I heard Secretary Azar talk about removing government barriers. This is one area where our strategies aren't always congruent. We want people in high deductible health plans. This is an area where we can't have someone in a high deductible health plan with an HSA also getting direct primary care. So that's something we're working with our friends here in DC on solving for. I'd love to get that fixed, because everybody, those strategies should be congruent, and we want everybody to be able to get better primary care. So I will end with that.
Yeah, thank you. And before we go on to Rishika, I'd question, and it's in part anticipation of what MyFam might talk about, if you could comment on the importance of steering of patients to the providers that you prefer to work with in your strategy.
Yeah, we've taken we decided to move pretty strongly into the space with a fairly large financial incentive for our employees to take this. So we really wanted it to be simple for them to understand. For a family, they save in hard dollar cost about $1,000 a year for moving into an ACO, electing that as part of their plan. And we have probably 35% enrollment in these ACOs in populations where they're eligible. So we've gotten a decent amount of movement. It's scaled up every year, so I think it's good. We're getting good word of mouth. But it's really, from our vantage point, it's the incentive that we can provide that will really drive the behavior.
Yes,